Hello, my name is Dr. Heather Chen-Yost, and I will be presenting February's eJournal webinar. The topic of my paper that I'm discussing is the utility of TRPS-1 immunohistochemistry in diagnosing metastatic breast carcinoma in cytology specimens. And I have no disclosures to report, and nor do any of the other authors who are participating today. So I am currently a cytopathology fellow at the University of Michigan, and next year I will be a thoracic pathology fellow. And we are lucky to be joined by two of the authors today who will introduce themselves.
Hi everyone, this is Dr. Seema Khutti. I'm assistant professor at Northwell, New York, and I practice cytopathology and gynecologic pathology. Thank you for having us.
Hi, my name is Nalan Yurtsever. I'm a fourth-year pathology resident at Zucker School of Medicine at Hofstra Northwell. I will be doing transfusion medicine fellowship next year.
Okay. Thank you so much for joining us. We're really lucky to have you both come here and then contribute your thoughts to the paper. So our objectives for the presentation today are to discuss the new immunohistochemical marker TRPS-1, to compare TRPS-1 to other IHC markers such as GATA3 and SOX10 that are used in identifying metastatic breast cancer cytology specimens, and to evaluate the intensity of TRPS-1 positive specimens compared to GATA3 and SOX10. So breast cancer is one of the most common cancers worldwide. It causes about 1.3 million cases, and about 680,000 deaths happen per year worldwide due to breast cancer. About 30% of breast cancer patients will have metastasis, and 6% of patients will have metastatic breast cancer at first diagnosis. The 5-year survival rate for metastatic breast cancer is not great. It's about 29% in women and 22% in men. So cytology can play a role in detecting metastatic breast cancer. There are many examples that we are familiar with where metastatic breast cancer can present, such as in pleural effusions, lymph nodes, bone, and soft tissue. The clinical history can be helpful when you are working up a specimen if you're suspicious for metastatic breast cancer, but oftentimes you do need immunohistochemical markers or IHCs to prove that the origin of that cancer is mammary origin or breast. And this can be really tricky when you have a triple negative breast cancer. So there are many examples of different types of triple negative breast cancers, and by this we mean breast cancers that are negative for ER, PR, and HER2. There are invasive ductal and lobular carcinomas that can lose these markers, but then there are other cancers to consider too that occur in the breast, such as metaplastic carcinomas and non-metaplastic carcinomas such as medullary, rare entities such as adenosquamous, and some of the salivary gland type cancers such as secretory. There are multiple different IHC markers that over the years people have discovered that have been useful to identify cancer of mammary origin. Some of them are GATA3, mammoglobin, GCDFP15, and recently SOX10 for triple negative breast cancers, and TRPS-1. For the purposes of this paper, we're going to only discuss these three markers, as these were the only three markers that were worked up in this paper. So I'll discuss GATA3 first. So GATA3 is known to be a key mediator in luminal ductal cell differentiation and ER signaling. The IHC is frequently used to detect breast cancer, but unfortunately it's not specific. Most notably, it's also expressed in urothelial tissue. And in triple negative breast cancers, sometimes GATA3 does not present, so it's only reported to be expressed about half the time. SOX10 is a newer, not a new marker for us per se, but has been used more recently to look at triple negative breast cancers. In mammary cells, it can be associated with the epithelial to mesenchymal transition and has been reported in some studies to be positive in about 40% of triple negative breast cancers. It's typically combined with GATA3 as part of a panel, and which can be useful because sometimes SOX10 is positive in GATA3 negative metastatic breast cancers. The only problem is that it's also not specific and can be positive in other lesions that most of which we know of, such as melanoma. So it's, caution needs to be used with this marker. So TRPS-1 is short for trichorhinophalangeal syndrome type 1, and this is part of the GATA transcription factor family. It's found to be overexpressed in breast cancer and little to no expression in normal tissues. It regulates the mesenchymal to epithelial transition and vice versa, and it can also drive carcinoma cells to lose some epithelial characteristics such as E-cadherin. Outside of the breast, it is expressed in some other malignancies, so it can be expressed in androgen-dependent prostate cancer, and it has been shown to regulate apoptosis sensitivity in chondrocytes. So the TRPS-1 IHC recently has been shown to be a fairly sensitive and specific marker for breast carcinoma, including in triple-negative breast cancers. In some papers, it has noted that it has had better sensitivity than GATA3 for both mesenchymal and non-mesenchymal triple-negative breast cancers. And most importantly, it has showed little to no expression in other tumor types such as urothelial carcinoma, lung adenocarcinoma, pancreatic adenocarcinoma, and colorectal adenocarcinoma, which can be useful when you present with a cancer of unknown origin. So the first question I have for our presenting authors, and I'll address this to Dr. Yurtsever. In real practice, what markers do you use when you roll in or out breast primary at your institution?
So for breast, we use GATA3 most frequently. Rarely, we will also use mammoglobin. If we are suspecting triple-negative breast cancer, we also utilize SOX10. Since we did our study at our institution, I think everybody has been using TRPS-1 as well.
All right, great. Yeah, I think that sounds similar to what we do here too. We usually do a bit of a panel, including GATA3 and TRPS-1 recently. So last night we did a Twitter poll for those who were able to attend. So here are the results. It looks like most people primarily use GATA3 when they're looking for breast cancer in cytology specimens, but a few people use GCDFP1 and mammoglobin. And so we also posted a question to see what IHC markers do people use for triple-negative breast cancer, and GATA3 and SOX10 were the predominant ones that people use. And then we asked if people have heard of TRPS-1 as an IHC marker for breast cancer, and about 60% had not heard of it. And for those who might have heard of it, about only 30% have this in their catalog. So the goals of our study that we will be discussing today is to evaluate the performance of TRPS-1 IHC for metastatic breast cancer cytology specimens, to compare the performance of TRPS-1 to GATA3 and SOX10, and see the rate of positivity in breast cancers that are ER, PR positive, HER2 positive, or triple negative. So I will pause for now to see if there's any questions. Okay, so no, never mind. So that's just but yes, please post your questions and comments in the question box, and we will address those at the end of the presentation. So I'm going to go over the materials and methods part of the paper. So the authors of the study selected cytology specimens from January 2020 to October 2020 that were diagnosed as metastatic breast cancer. The other qualifications is that the cell block needed to have greater than 20 tumor cells, and the hormonal status had to be available. So they need to know the ER, PR, and HER2 status. So with this, they divided up the cases into 3 groups. There was the ER, PR positive, HER2 negative group, and the HER2 positive group, regardless of ER, PR status. And lastly, the triple negative breast cancer group, also known as the ones that were negative for ER, PR, and HER2. So the second question I have for the authors, and I'll address this to Dr. Khutti, is are ER, PR, HER2 performed routinely upon confirming breast origin in cytology?
Thanks for the question. Yes, so for all FNA cytology, once the metastatic breast carcinoma is confirmed, we do upfront order ERPR and HER2 on all cases. However, for any case which is a fluid cytology specimen, and even if it is breast metastatic cancer, we do not order it upfront because they are fixed in alcohol, and the guidelines are for formalin fixed tissue only. So, however, if clinician request us, we do order it later on after the clinician's request, and hence that's what we do in our practice currently.
Yeah, do you add a disclaimer that because it's fixed in alcohol and not formalin, there might be some discrepancy?
Sure. Yes, yeah, we do add that disclaimer for fixation.
Okay, sounds good, thank you. So they performed IHCs on the specimens. So there were TRPS-1, GATA3, and SOX10. If a IHC was positive, it had to be nuclear staining. If the specimen had membranous or cytoplasmic expression, that was considered negative. So the next question I have, and that'll be for Dr. Yurtsever, is regarding the selected cases included in the study, were the stains performed at the time of diagnosis, or were there any stains performed later for the study purposes?
So we picked the cases that only had hormonal status available. So all the ERPRs were already done. Most of the GATA3 was also done. We only had to do a few of them just as like a repeat. TRPS-1 was done newly on all of them because none of them had it at the time. And we also did SOX10 and most of them because some triple negatives had it, but not the other ones. So we had to do those as well.
Okay. And then did you use the same protocol when you had to do the, like, say, GATA3 and SOX10 afterwards?
Yeah, we use exactly the same protocol as we did before and after.
Okay, sounds great. Thank you. So with the IHC results, they came up with an IHC score. And so that was the percentage of immunoreactive tumor cells multiplied by the intensity number. And this was done on a 4-point scale. So for the percentage number, depending on how many of the tumor cells were positive, they assigned a nominal score to it. And same with intensity number, to see if it was either negative, weak, moderate, or high. And with that multiplier, then they could assign it to different categories, such as negative, low positive, intermediate positive, and high positive. And anything that was considered negative and low positive essentially were considered to be negative for that IHC. They used a p-value of 0.05, and then for the IHC scores, a Fisher exact test was performed. And for the intensity percentage scores, an analysis of variance test was performed to compare the 3 IHCs. So I'll now move on to the results. So there were 60 cytology cases of metastatic breast cancer that were included in this study, and that included 33 body fluid specimens and 28 FNA specimens. And so you can see here where each of the where the distribution was. For the body fluids, primarily these fluids came from the pleural cavity, and then for the FNA specimens, they were primarily from the lymph node. In our ERPR positive group, there were 37 cases, and TRPS-1 was expressed in all of these cases. 35 of them were high positive, with 1 that was intermediate positive and 1 that was low positive. GATA3 was expressed also in all of the cases, and all were high positives. SOX10 performed the worst out of this group, which is not surprising given what the previous literature has published. And it was only intermediate positive in the 1 case that it had staining for. In the HER2 positive group, there were 7 cases. TRPS-1 was positive in 6 out of the 7 cases, with 5 of those that were high positive. GATA3 was positive in all of the cases, and 6 of those were high positive. SOX10 did not stain for any of these cases. So the group of interest in triple negative breast cancers, there were 17 cases total, and TRPS-1 was positive in all of these cases, and 16 of those were high positive. GATA3 was positive in about 3/4 of these cases, with 9 of them being a high positive, and the others intermediate, low to straight negative. SOX10 was positive in about 30% of the cases, and all of these were high positive. So here is the table from the paper outlining the findings that we had. They also wanted to compare the intensity score for these 3 markers. So you can see that TRPS-1 on average seems to have a slightly higher intensity score with 2.3 to 2.9, whereas GATA3 was 1.8 to 2.9, and SOX10 has the least intense score, about 0.3 to 0.8. So we can see this diagram presented in the paper, and these are all examples of triple-negative breast cancer specimens. So you can see on the left-hand column, that is GATA3. It is positive in the first 2 cases, but negative in the last case. TRPS-1 is positive in all these cases, and SOX10 is positive in 2 out of 3 cases. So you can see how one would be able to identify the IHCs in such cases. So here's a table outlining the expression and the intensity scores and the percentages that were identified in these cytology specimens. They also wanted to compare if there was a difference between body fluid and FNAs to see if there was any difference in which IHCs were going to be positive or negative, and they found no significant difference for all 3 IHC markers, which is good to know. So the next part of the study was to compare TRPS-1 to the other IHC specimens, or IHCs. So TRPS-1 versus GATA3 in triple-negative breast cancers. There were more positive cases that for TRPS-1 versus GATA3, but the p-value was not quite statistically significant, but it was significant when we looked at the mean percentage tumor cells that were positive. It was higher in TRPS-1 than GATA3, and the intensity score was higher in TRPS-1 versus GATA3. When TRPS-1 was compared to SOX10, for case number, mean percentage, and intensity, there was a statistically significant difference that TRPS-1 outperformed SOX10 in this case. And so here are the tables from the paper outlining the findings. So now we'll move on to the discussion. So when we look at other papers for TRPS-1 in breast cancer, and it is a relatively new marker, we do see that it does seem to perform fairly well in different types of breast cancers on surgical pathology. So in this paper by Yoon et al., about 100% of triple-negative breast cancers that were invasive lobular carcinoma showed TRPS-1 IHC expression. 99% of triple-negative breast cancer of no particular subtypes were positive, and 95% of metaplastic breast cancers were positive. A study by Wayne et al. Showed that TRPS-1 was expressed in about 95% of spindle cell, chondroosseous, and liposarcomatous components of malignant phyllodes tumor. So these papers show that it's not just the conventional breast cancers that it might be positive in. It is unfortunately negative to variable in certain subtypes of breast cancers. These tend to be the rarer ones, but it is important to note. So neuroendocrine carcinomas of the breast were shown to be negative for TRPS-1, along with African carcinoma, and that one appeared to be GATA positive, but not TRPS-1 positive. And some salivary type carcinomas, such as secretory carcinoma, cynic cell carcinoma, and adenoid cystic carcinoma were negative for TRPS-1. When other papers looked to compare the sensitivity of TRPS-1 to GATA3, for triple-negative breast cancers, one of these papers discussed showed that TRPS-1 was more sensitive, and another paper showed that it had higher positivity rates for metaplastic carcinoma than for GATA3. When looking at TRPS-1 versus SOX10, this paper showed that TRPS-1 also had a higher positivity rate than SOX10, and SOX10 was expressed in none of the invasive lobular carcinomas that they had looked But as we learn more about TRPS-1, we have also learned that it can be variably positive in other cancers. Some of them are, other carcinomas such as salivary duct carcinoma, serous carcinoma of the ovary, lung squamous cell carcinoma. It looks like it is expressed in about a quarter of these cases. And then as such, theoretically, skin squamous cell carcinoma can express TRPS-1. And TRPS-1 can also be positive in some sarcomas, such as conventional chondrosarcoma, and it seems to be about 50% of osteosarcomas of the bone, and possibly more as we learn more about this marker. So the next question I have, and I'll address this to Dr. Khutti, is has your institution found a non-breast cancer that was positive for TRPS-1?
Yes, of course. So we routinely now, because we have added TRPS-1 either in a primary unknown origin cases when we know that GATA3 can be negative or it can be non-specific. So as an add-on, TRPS-1 is also added to many cases where we don't have history of breast. So in my experience, what we have seen in many peritoneal FNAs, which ovarian carcinoma, and most commonly the high-grade serous carcinoma ovary, present as peritoneal mets, and they often have been positive for TRPS-1. And our percentage might be a little bit more than what is reported to be 14%. So that's what our experience is.
Okay.
But however, as you mentioned, like squamous cell carcinoma, they tend to be positive more than 20%. So I think that might be the general, but usually when it's morphological diagnosis, it's not ordered in our practice for squamous cell. So.
Okay, thanks. So in conclusion, with this paper, this is the first time that we have looked at TRPS-1 in comparison to GATA3 and SOX10 in cytology specimens, and it was shown that it has similar positivity rates as those markers for ER/PR and HER2 positive metastatic breast cancers as compared with GATA3. TRPS-1 did have a higher positivity rate in triple negative breast cancers versus GATA3 and SOX10. And maybe most importantly, it did have a higher positive intensity score than other IHC markers in most conventional breast cancers. And that can be something that might be useful just because it might just be easier to identify than possibly GATA3 and SOX10. But overall, I think in conclusion, TRPS-1 can be a useful marker to identify metastatic breast cancers for triple negative breast cancers especially. But it can't just be part of a panel with the other markers that people conventionally use, especially as we learned, TRPS-1 can be positive in not just metastatic breast cancer. So a panel might be recommended along with GATA3 or whatever else that your institution uses to identify breast cancer. So these are my references. And that concludes the end of my presentation. So I'd like to thank the ASC eJournal Committee for giving me the opportunity to talk about this paper. I'd like to thank Joanne Jenkins for organizing this discussion. And I'd like to thank our authors who were able to participate and our first author to Dr. Mohammed Abdelwahed. And I'd also like to thank Dr. Shinjin for being the mentor on this project. So now I'll open up the floor to any questions or comments that people have and open up the floor to discussion for this marker. Do you use it in your practice? Have you found it to be helpful in diagnosing metastatic breast cancers? Have you found it maybe not as easy to interpret as this paper, the authors of the paper found it to be?
My sincere apology to everybody. There was connection problems today for me to get on time to the presentation. You guys did wonderfully, so you don't need me, but I just wanted to say thank you, especially to Heather, because I told her that I will kind of start off and do things, but it kind of didn't work that way, but it was very nice. Thank you very much, and thanks to the authors who joined us, some from far away. So we really, really appreciate everybody's participation. As I said it in the chat box, this is the good time for everybody who has suggestions or comments or questions to kind of join us. And as you mentioned, just let's bring it in. I do see one. Let's see what is that. What would be the best way to distinguish metastatic breast versus metastatic ovary where both are TRPS-1 and CK7 positive?
So I can answer that. We usually always order PAX8 for all peritoneal carcinomatosis, as that's the most common presentation for ovarian carcinoma to present. So especially for peritoneal, or if radiologically there is a history of pelvic masses, we upfront order PAX8 when there is no prior diagnosis. So along with, and these cases, many of these patients have BRCA positive. So always, of course, the breast is indifferential as well. Either they are known case or they might have later on. So that's the reason we order upfront.
Very good, very good. I think that's a very fair answer to that, because again, all the immunohistochemical stains that we use, they all have their ups and downs. They have many different things, and sometimes the differentials that we want to look at them, they would have some positivity, lower positivity, this and that. And as a whole, I think clinical history, as you mentioned, and also it's usually a panel that helps. If any single one of them doesn't do the job and may mislead us. And but the thing that is important in cytology, and to a certain extent in the core biopsies, is a matter of how to deal with the number of cells and quantity that we have. So it becomes an art and science, I guess, of cytology to kind of pick and choose between what you think based on the morphology, based on the history, digging into tons of papers on the charts in the electronic records to figure out in one corner somebody wrote something that you can hang on to it. So it's a lot of all of that, and I know that all of us go through that, but every little bit helps, I guess. So I'm actually excited. We don't have it where I work right now, but it is important to be able to at least use something that could be helpful when you really think it should be a breast, or they really think it should be a breast cancer. So and GATA has let me down many times. So it becomes like, okay, it's GATA negative, but you know, based on this and that, it would be a breast cancer. So that's very good. So we have one more question. You mentioned that adenoid cystic carcinoma is negative. Was that a studies in the solid variant, as it's frequently a difficult diagnosis in triple negative breast cancer? So I guess the question is the study that talked about adenoid cystic being negative, where they're looking at the solid variant, which is usually common to the differential diagnosis.
I don't think they mentioned in the paper if it was specifically the solid variant or not. I have to look at it again, but I don't recall that being if it was like just the conventional adenoid cystic carcinoma, or they were looking at solid variant. I don't know if they were just staining it just to see if it would be even positive or not.
And to give me a little bit, I want to clarify it. This is the adenoid cystic carcinoma based on that study from the breast origin, or was it adenoid cystic carcinomas of the salivary gland?
No, this was breast origin.
Okay, yeah. All right, very good, very good. All right. I'm not seeing any other questions yet, but we still have time. There may be more questions coming up, so we'll
I know my co-fellow will be presenting a study similar to this at USCAP, and then they found that TRPS-1 wasn't as sensitive as GATA3, at least over in our institution, and that it did stain maybe some mesothelial cells. I don't know if other people have experienced that same issue too, like having some like not the cleanest background staining.
So you're talking about any general cytology specimen, like what was the cohort?
So they were also in breast cancer, like metastatic breast cancer, and they did, you know, similar to you, the different hormonal like ERPR, HER2, and like different combinations of such. And I think they concluded overall, like for triple negative, like they didn't have as much sensitivity as this paper did. But they also found that mesothelial cells, like for some reason, had like some background staining with TRPS-1. I don't know if other people also had that issue too.
No, we didn't have any mesothelial cells staining.
Okay.
Yeah.
That's interesting because usually the background staining becomes a problem when we're looking at the cytoplasmic membranous stainings. Usually nuclear staining at least gives you a feeling that, okay, whatever is staining in the nucleus is what it's intended to stain. So that's why I usually like to use, if I have a choice, I usually like to use nuclear staining, because especially in cytology, because the cells are kind of, separated out, detached, kind of floating in whatever medium that you use to make your cell block. So there's a lot of that background staining coming to play. But that's interesting. I guess we'll stop by at the USCAP poster to see what exactly was it.
Yeah. I think it's the Wednesday session in the morning for the site for the poster session. So yeah, check it out.
I'm not going to be there Wednesday, but I will follow it up to see what it was. Very good, very good.
Also joining in. Thank you, Heather. That was an invitation. In my personal limited experience of using TRPS at Columbia Pathology, I have seen some background staining in the lymphocyte, but it's very weak and easier to distinguish from the malignant cells.
Okay.
Very good. Dr. Bascota, thanks for joining. Today, I kind of let the team down because I couldn't connect myself on time, but
I'm so sorry, Dr.
No, I know you had a reason not to, but I didn't. So I'm glad you joined in anyways. All right, very good.
Let's see, we have a new question here. How does TRPS-1 compare with mammoglobin? Yeah, so I don't actually know the answers to that question. I don't know. We rarely ever use mammoglobin these days in our institutions. I don't even know, at least for cytology specimens in my experience, so I don't even know how I would compare the two. I think it's because it is just easier to look at TRPS-1 and GATA3 than mammoglobin, so we sort of don't really use mammoglobin much anymore, at least in my experience. So I don't know what other people have found in their, personal experience.
We also rarely used mammoglobin. Before TRPS-1, it was a little bit more useful when we did have a history, or when there was a history of urothelial and breast, and we couldn't distinguish because we know that GATA can be positive. So in those scenarios, yes, we have used mammoglobin, but not in recently past.
Right. And my anecdotal is that mammoglobin always lets me down, because it's if the cancer is well differentiated and you kind of have an idea that it looks like a breast cancer because it's making the ducts or this, that, and that, it does work. But when it becomes poorly differentiated, then you kind of lose hope, because many times, even though you know it's a breast cancer because you're looking at a breast cancer case, it doesn't necessarily work. I have been using it in conjunction because sometimes you want to kind of increase your chances of getting it. And again, not just on cytology, even on SearchPath. But I have never found it helpful and like an aha moment. Oh yeah, it's mammoglobin positive, so it's breast cancer. So I think, again, my question to the person who asked the question is that, have you found your mammoglobin useful in your other adventures with it, like not necessarily cytology or anything else? Because I personally have not. And as we said earlier, because it's cytoplasmic, because it's not nuclear, it kind of becomes harder to interpret it in a background of a cell block. at least in my opinion. Okay, let's see. There is another. Yeah, go ahead.
I was gonna say, and I think it seems like, based on our Twitter poll, that most people have moved away from those markers like hemoglobin and GCDFP15. Yeah, I think like those are kind of fallen out of favor, it seems like, in the past, like, few years or so.
Right, and that is true. The same question came back at they only use GATA3, and that's usually what I use, not having this magic marker now. So I usually just use the GATA3 and hoping for the best. So yeah, I guess that's something to. I assume that as it becomes more and more known about and available, and many labs may bring it on to kind of have it, we may know more about it. Just like any other markers that come out, at first we kind of get very excited about, oh, this is going to be great for this and that, and then little by little we'll realize that no, it can be positive in this, it can be negative in that. So, but I think it's actually a great thing, because again, we all have this issue with the triple negative breast cancers. Many of them are very high grade cases, so sometimes you look at them and you feel like, that is this even breast cancer that is triple negative? So it would have been not positive for any of these things if it wasn't a breast cancer. So I think it's good to have more opportunities to kind of tackle the main question that what is the origin of this tumor and what is it doing in places that it shouldn't be. So very good.
Yeah, how does TRPS-1 stain in sclerosing adenosis? My understanding of the stain is that it's not expressed in normal tissue. So I am not sure personally how it would stain in sclerosing adenosis. I would have to look that up as well for this.
I think even the prior studies in search pathology for breast carcinoma, primary breast carcinoma, I don't think they mention about the background breast being stained or not, or which component stained. So I think maybe that could be another study to look at it.
Yeah,
but not because it's reported to be negative or expected to be negative.
Very good. Very good. Let's see. So, Dr. Khutti, tell us about your protocol when you get, a metastasis of unknown primary. I know you mentioned it, but just to recap, to learn from different practices and different settings.
Sure, of course. So, as I mentioned, I think for me, most important is the radiological findings, where is it peritoneal carcinomatosis? Then, of course, as we know, the GYN and GI are the most common. Then other comes in later if there is other known history along with that. So PAX8 and CK720 with CDX2 are always in panel along with any other known primary with patient having passed. However, if it is lung, we would add TTF and exclude that primary lesion, that add other panel as well. So I think and the fluids, as we know, is always challenging. So when it's fluid, we tend to order more lineage-specific markers when we know that it could be involved with anything. Pleural fluids less likely, but ascitic fluid again. GYN, GI plus TTF in all. If it is male patient, then GYN is excluded by its own, so we would include TTF also and prostate markers.
Very good, thank you. I just have one question, it just dawned on me. In your cohort of patients that you did stain, was there any male breast cancer?
I think there was one male, maybe we can go back to, I don't know if you mentioned, but we did mention that.
That's okay. I was just thinking about it because, again, right.
I think there was,
right.
I don't know if you mentioned whether it was male to female ratio or not.
Right. Very good. No, the reason I kind of said it is just based on, every now and then some cases in your head come back to you and kind of you kind of think about them. And I kind of learned that early on. With women, breast cancer, majority of time they know that the patient has breast cancer. So it's not an unknown primary per se. So majority of patients have that diagnosis. Men, on the other hand, I think breast cancer kind of comes as a background thought. So not everybody jumps into kind of doing something for breast cancer. So, and the funny thing about also the other types of breast cancer, lobular, which is kind of notoriously hard to even be picked up in the breasts of women to begin with, and everything else. So sometimes they do present with effusions. There are one of those type of breast cancers that they don't necessarily follow the path of going to axillary node. They do have serous capacity to go to all the pleural effusions or even peritoneal effusions. So that's something that, I saw from your paper that lobular carcinomas, actually, they did very well with this marker. So I think that's something to kind of, I guess, be hopeful about. I don't know, hopeful may not be a good name to say, but at least to know that it is helpful in that situation. And we definitely need to know about the mesothelial cells, because that's not going to help us. So, we'll see how that goes.
I think what we experienced, the main striking evidence which we noted was the intensity of the nuclear stain. So I would say that even if some studies and if background cells, as mentioned by Dr. Sukriti, that lymphocytes, what she has observed, yes, there will be rare cells, maybe, especially as we know in fluids are notorious, that they will show this background non-specific, but it will always be focal few rare cells with weak positivity. However, the intensity, what we see in a real true positive, is really very high and triple negative for TRPS-1. So that would, I hope it will be very useful. Yeah, even if mesothelial stain will be weak.
Right. No, that sounds good. That sounds good. Very good.
I don't see any other questions in the box here.
No, me neither. So, I think if everybody's okay with it, we can, call it done. And we'll give people some 15 minutes back, so that I know everybody is super busy. And again, I really thank everybody who joined, the audience, as well as the presenters. And I again apologize for my tardiness. It was not intended to be. I checked all my connections in the morning, and I checked it again about like an hour before the presentation, because somehow I'm always afraid that it may happen, and today it actually happened. So I guess that's how it's gonna be, but thanks again. And this was great, and it seems like we will be hearing about this more and more, and it's great to have started the process, so that's great. I really appreciate it, and appreciate everybody joining it, and it really is great when the authors can join us, so we really appreciate that. Thank you very much, and anybody else, please, if you have something to say, please go ahead. I'll stop.
I would just like to thank Dr. Jing and Heather for choosing our article and also getting us involved in the panel and setting up us as a panelist. So thank you again.
No, thank you so much for being able to make it here. I know it's very late for you, but I think like your presence here really added to the presentation. It was really great to have your insights into the paper. Thank you, Nalan, too, also for being able to join. So yeah, no, thanks for the opportunity also to for me to present in this webinar.
Nalan was also a real backbone for this article. She did all the stats, so kudos to her.
Yeah, no, seriously.
Very good. Very good. have a wonderful afternoon, evening, wherever you are. So, and till the next time. All right.
All right,
Bye-bye.
bye.
Goodbye.